Welcome to CivilizationX. Hospitals treat failure late, then create new risk inside the building. Continuous monitoring can catch deterioration before a bed is needed. The strange part is that the body often starts broadcasting danger long before pain, fever, or collapse. Medicine has been organized around the place where crises end up, not the signals that begin them. At 4:40 on a Thursday morning, a parent stands barefoot on a cold kitchen floor, rinsing a plastic medication cup. In the next room, a child sleeps beside a half-packed backpack, already trained for blood draws, waiting rooms, and disinfectant before sunrise. Then, the phone vibrates. Overnight monitoring has flagged a pattern before the drive even begins. For families like this, hospital care means missed school, missed work, and a life organized around deterioration. More than 45 million preventable hospitalization admissions were reported in the US between 2005 and 2017. Now, the tools are changing. AI systems such as Delphi, built by researchers including Thomas Fitzgerald's team at the European Molecular Biology Laboratory, analyze medical history to forecast over 1,000 diseases. In some cases, up to 2 decades ahead. Remote sensors stream oxygen, motion, heart rate, sleep, and blood pressure. The hospital starts to look less like the start of care and more like the fallback. The real claim is not that hospitals disappear. It is narrower and more serious. If disease becomes readable as signal before symptom, then diagnosis, monitoring, and some intervention can move outward into homes, networks, and smaller clinics. The engineering question is, what can safely leave the building first? Illness changes the body as data before it changes the body as experience. Heart rate variability shifts, temperature drifts, oxygen saturation falls, movement slows, sleep fragments, blood markers move out of range. Imaging picks up texture changes too subtle for the eye. Genetic mutations load risk years before crisis. AI is not intuition. It compares weak patterns across huge numbers of prior cases and asks whether this combination has preceded disease before. That is why the same architecture can connect 4 very different tools: prediction from records, continuous monitoring at home, robotic precision when procedures are needed, and gene editing that may stop repeated missions before they start. This is where the old model starts to break. In specific detection tasks, AI is already matching or beating specialists inside hospitals. Tumor detection has reached 94% accuracy, surpassing professional radiologists in the reported study. Colon cancer detection reached 0.98 accuracy, outperforming trained pathologists. That is not AI helps a little. It means the hospital's diagnostic monopoly is weakening. Then the data showed something even more disruptive. Remote patient monitoring programs reduced admissions by 59% in high-risk patients. COPD readmissions fell by up to 53%. Among elderly patients, overall medical visits dropped 47%, and hospital admissions fell 40%. Telemedicine also cut hospital length of stay by an average of 1.01 days. Much of what hospitals do is not tied to the building. It is tied to sensing, triage, escalation, and coordination. When escalation is necessary, precision matters. AI-assisted robotic surgery has shown a 25% reduction in operative time and a 30% decrease in intraoperative complications compared with manual methods. And some diseases may never need repeated admissions if the root mutation is corrected. In late 2023, CRISPR received its first approval for sickle cell disease and transfusion-dependent beta thalassemia, with potential relevance to more than 300 conditions. But hospitals are not just expensive, they are hazardous. An estimated 518,000 healthcare-associated infections occurred in U.S. hospitals in 2023. About 1 in 38 patients had at least one infection on any given day, even though rates were 27% lower than in 2015. In 2017 alone, 3.5 million potentially preventable adult inpatient stays cost $33.7 billion. Global health spending reached $8.3 trillion, or 10% of global GDP. Virtual care could shift roughly $250 billion of that. By 2025, about 71 million Americans are expected to use some form of remote patient monitoring. So yes, Technology can keep many people out of hospitals, but solving that creates an entirely different problem. Accuracy is not enough. If a deterioration event affects 1% of 1 million monitored patients, and a model runs at 99% specificity, it still throws about 10,000 false positives, alongside roughly 10,000 true alerts. Positive predictive value is only 50%. That means clinician overload, frightened families, unnecessary escalations, and a system that can be excellent in benchmarks, yet unstable at national scale. As Mani Menon puts it, robotics and AI still need trained humans behind the controls. The realistic future is selective replacement. Trauma bays, ICUs, transplant centers, and complex surgical hubs stay. Routine surveillance, chronic disease management, follow-up, and some procedures move outward. But that only works if access is broad. Broadband for the family at home, usable sensors for elderly patients, stable connectivity for rural clinics, representative training data, secure systems, and affordable therapies. Jennifer Doudna called the first CRISPR approval a win for medicine and for health equity. It becomes one only if neglected patients can actually reach it. Back in that dark kitchen, the alert led to a same-day medication change and remote specialist review. The child stayed home. That is the design target. Fewer buildings doing more rescue, and more intelligence preventing rescue from being needed. Jay Bhattacharya's CDC warning still stands. Hospitals remain places where care and harm can coexist. What evidence threshold should regulators and health systems require before AI-guided, home-based monitoring is trusted to replace a hospital admission for high-risk patients at national scale? The constraint is real. The data exists. Whether the systems built around it can act on it at scale? That is the next engineering problem. Stay with CivilizationX.